you for joining us tonight. We are so excited to have founder and fellowship director, Dr. Pamela Smith, share her expertise in metabolic and functional endocrinology. This fellowship program provides advanced medical education on health promotion, wellness, prevention, and management of disease with evidence-based metabolic, functional, and nutritional approaches. This fellowship provides unparalleled content, groundbreaking research, knowledgeable speakers, and valuable resources that enable today's health practitioners for sustained success and growth. True wellness is more than the absence of disease. Tonight we are going to highlight Module 1, a metabolic and functional approach to endocrinology. This module provides an overview of the functions and interrelationships of specific hormones in the body, including hormonal changes that manifest in men and women with aging. Metabolic, functional, and nutritional approaches to managing hormonal deficiencies and endocrine disorders, including diabetes and obesity, are covered in this module. We discuss how to best identify, test, and treat hormonal deficiencies and dysfunction, such as with hormone replacement and medication compounding. Dr. Pamela Smith spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center, and then the next 16 years as an anti-aging metabolic medicine specialist. She is a diplomat of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of metabolic, anti-aging, and functional medicine. She also holds a master's in public health degree along with a master's degree in metabolic and nutritional medicine. She has been featured on CNN, PBS, and many other television networks. She has been interviewed in numerous consumer magazines and has hosted 2 of her own radio shows. She is a regular contributor to Fox News Radio. Dr. Smith is currently the director of the Center for Healthy Living and Longevity and the founder and chair of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine. Dr. Smith is also co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morsani College of Medicine at the University of South Florida. She is the author of the best-selling books HRT, The Answers, Vitamins, Hype or Hope, Demystifying Weight Loss, What You Must Know About Vitamins, Minerals, Herbs, and More, What You Must Know About Women's Hormones, Why You Can't Lose Weight, and Why You Must Know About Memory Loss and How You Can Stop It. Her newest book, What You Must Know About Thyroid Disease, is due out this spring. Due to the high attendance this evening, please submit your questions by using the chat option, and we will address questions after each case and at the end of the webinar. Dr. Smith, we are all very excited to hear you share your expertise and how the Fellowship in Metabolic and Nutritional Medicine will transform your practice.
Good evening, everybody. We're glad to have you all here. I have to honestly say I am a very blessed person in the fact that I have truly had 2 fabulous careers in medicine, both very cutting edge, both very, very exciting. And when we look at metabolic medicine, it really is the medicine of the future here today. And I try and explain to people that it's not Star Trek medicine. This personalized approach is available for all of our patients. So tonight we're going to look at some of the science as to the endocrinology of the body. So first of all, a healthy patient. In order for a patient to be healthy and to stay healthy, they need to do 4 things. They need to eat as well as possible. They need to exercise on a regular basis. Personally, I hate exercise. I honestly don't get the high that some people get from exercise. I was really, really lucky to meet Jack LaLanne before he passed away. And I asked him, I said, Jack, how do I learn to like exercise? I don't like it. I was very surprised at his answer. He said he didn't like it either, but he enjoyed the results. And I personally exercise because it helps maintain memory. But very important on these 4 things to do. Patient also has to be nutritionally sound. And that's really different for everyone. We can measure 38 different vitamins in the body. We can look at amino acids, fatty acids, organic acids. We can measure neurotransmitters. We can really look at the science. And that's what I love about metabolic medicine. It is the most scientific field there is because we do measure. And as we age, our nutritional needs change. The body makes less lipoic acid, less carnitine, less coenzyme Q10. We process less vitamin D into its active form. All of those after the age of 50 do not work as well. So being nutritionally sound is important. We can help our patients do that. And then to be hormonally balanced, really to have a perfectly balanced hormones for the patient to do that throughout their lifespan helps them have enough energy. It also helps prevent anxiety, insomnia, mood swings, and depression. True story. I was speaking at a very large Catholic church to a group of women. And the priest, the senior priest, was there. And he grabbed me after my talk and he said, okay, we just talked about hormones for both men and women. Tell me, if someone's contemplating divorce, should I tell them they need to go see their doctor and be hormonally sound first before they contemplate it? Because it sounds like they could have anxiety, mood swings, insomnia, etc. And I laughed with him, but honestly, it's probably true. Hormones also help maintain vision, memory, and mobility. Very, very important things to have. So tonight's seminar is going to focus on case histories in hormone replacement for people at any age. We're going to look at different age groups tonight. So really, the first question we always ask is what level of sex hormones does an adult patient make in a day? Because it's hard to consider how much we would want to replace with if we did not know how much they produced in a day. So it's important to contemplate this before we do anything. Men, when it comes to testosterone, make 4 to 8 milligrams in a day. So it would be ludicrous to think that we would want to replace 100 or 200 milligrams of testosterone as a cream when men basically make 4 to 8 milligrams a day. We do know it gets very well absorbed. Those studies have been done. Also with men, if we give too much testosterone, it drives up insulin. We can make them insulin resistant. If we give too much testosterone in males, it doesn't stay testosterone. It goes into dihydrotestosterone, estrone, and estradiol. An elevation in estrogens in men or dihydrotestosterone increases their risk of heart disease. An elevation of estrogen in men increases their risk of prostate cancer. An elevation of dihydrotestosterone in men increases loss of hair on their head and prostate cancer. So very important to know if men do need testosterone and if they do, how much. In younger males, we don't replace testosterone if they have a normal pituitary. We give HCG. In some cases, we may give Clomid. All of this will be discussed in Module 1, along with insulin resistance and diabetes and osteoporosis. How about women? If you look at this graph, and this graph was given to me by Dr. Sahar Swadan, who is one of the professors in the fellowship in Module 1, you can see the 24-hour production rates of sex steroids in women at different stages of the menstrual cycle. So for example, let's take progesterone. As we can see, mid-luteal phase, the most that she would ever have during her cycle would be 25 milligrams. 25 milligrams. The most testosterone she would ever produce is usually pre-ovulatory, and that would be an average of 171 micrograms. So when I see people give crazy doses like 10 milligrams to a woman, that would be way too much. You can see women at the peak of making estradiol, pre-ovulatory, is 380 micrograms. So keep this chart in mind. And in Module 1, we're going to discuss it at length, looking a little bit more at what happens with the normal amount of hormone that is produced by the body. So with both men and women, we really want to turn back the clock about 20 years. If we're looking at hormone replacement in younger women, it really is about balancing. In fact, honestly, for both men and women, it really is all about balance. So if I was going to describe it in one statement, when it comes to hormones, it is about balance. Any questions before we begin the cases?
Dr. Smith, I don't see any questions at this time.
Okay, great. Then we will move forward to case number 1, which is a 52-year-old female with the chief complaint of fatigue and insomnia. And these are actually my own patients with their own labs. Past history is positive for surgery to the right foot. Family history, the patient's mother has Graves' disease. The father is healthy. Social history, she works as a school teacher and has a lot of stress at her job. Remember, the hormones in the body really are a symphony. So all of the hormones have to play in tune. They're a web, so they're interconnected. And this person was already on progesterone when she came to see me at a pretty good dose of 300 milligrams sustained release. And because she was menopausal, she had not cycled for over 1 year, she was taking it nightly. Physical examination was within normal limits, except for the patient appears very tired. So what do we want to do with this patient? What we wanted to do was to do a salivary test. When we look at hormones, we can measure them by serum, we can measure them by a 24-hour urine, or we can measure them by saliva. When we do serum testing, it only tells us what goes on in the serum. It does not tell us what goes on in the rest of the body. And both men and women have hormone receptors in obvious locations, but really throughout the body. So men have testosterone receptors in their eyes. Women have estrogen receptors in their eyes, for example. So with serum testing is okay to look at patients if they're not on hormones. But once they're on hormones, we want to see what's going on in the whole entire body. And so we can get a salivary test, which also gives us the active hormone, how much is available for the body to use, and not the stored or bound. Or we can do a 24-hour urine. In doing a 24-hour urine, it is commonly the metabolite of the hormone. So for example, we would not really be getting a measurement of progesterone, but we would get a metabolite of progesterone. In the perfect world, it would be great to do both saliva and a 24-hour urine. In this patient, in this lab value, green is the average American, and red is 1 standard deviation above and 1 standard deviation below. This patient, again, came to me only on progesterone, and she has no testosterone. So it's so low they can't measure it, in case you can't see it on the slide. So do we want to start her on some testosterone? We do. Start low and go slow. So I never give more than 4 milligrams of testosterone, and we always give it to women transdermally. Oral testosterone, which is methyltestosterone, increases the risk of cancer of the liver according to medical trials. So we want to give it transdermally to the patient, usually on the thigh or behind side. And with testosterone, the patient needs to rotate sites. If she puts it on her right thigh, for example, all the time, she will grow hair there. So we want to start her on testosterone, and we could start anywhere from 0.75 milligrams to 1 milligram cream. The next one underneath testosterone is estrone. We don't replace that one. The body will take some estradiol and make estrone. So we don't give what's called triest, meaning E1, E2, and E3. We just give biased and replace E2 and E3. Women do make 3 estrogens, E1 estrone, E2 estradiol, and E3 estriol. The one below estrone is estriol, E3. This one was non-measurable. And if you go over to the next column, you'll see estradiol. It really needs to be dead center of normal or at least 6 to be functional. And so this person was at 5.1. So she would benefit from estrogen. So again, we're not going to give E1. We're going to give E2 and E3. But she has pretty much close to normal E2, but no E3. And that's the great thing about compounding. We'll make a combination, write a prescription for E2 and E3, and we're going to use 90% E3, because she doesn't have any, and 10% E2. We can just start with a small amount, 0.25 milligram cream, and then we would repeat the study in 90 days. I always repeat the hormones in 90 days after the patient is started on them. She's already on progesterone, and if you remember, I said that was a pretty good dose. It was, and you can see it's way, way high. So it's more than a standard deviation above, and so we need to back down on her dose. She was on 300, so I decreased it down to 130 milligrams. That will make the E2 and progesterone ratio normal. So the one on the bottom, there's the progesterone to E2 ratio, which is too high at this point because of too much progesterone. This is the patient's melatonin. It's important that we measure melatonin because if you just give melatonin that's not measured, and melatonin you give too much, then serotonin can go down. In this result, the patient's morning and 5 p.m. melatonin were normal. But again, dead center of green is what we're shooting for, so the 3 a.m. specimen is too low. And this could be due to the patient needing melatonin, or she left the lights on when she did the 3 a.m. specimen. And so when I asked this patient, she actually didn't need melatonin. She had left the lights on. As it turned out, when we gave her the right amount of progesterone, she slept. Remember those symptoms she had of anxiety, irritability, insomnia, mood swings, and depression? They were from too much progesterone. Progesterone is very tricky. You have to get it right. Too much or too little can cause the same problem. This next graph is the big one on the top is cortisol. Again, we want dead center of green. Yellow is red is 2 standard deviations above normal here on this graph, and yellow is 1 standard deviation above. So we have cortisol too high in the morning. It's normal around noontime. At 4 p.m. and 11 p.m., it's too high. So what do we want to do? We want to give adaptogenic herbs. We want to have the patient do stress reduction techniques and some calming herbs. Adaptogenic means that it works if the cortisol is too high or too low. It will adapt. Things like ashwagandha, ginseng, rhodiola. Calming herbs like chamomile, lemon balm. It will take 1 to 2 years to normalize cortisol. If the patient's not on a multivitamin, and this person wasn't, then do put them on a multivitamin because the adrenals need a lot of different nutrients to repair themselves. This patient's DHEA was not dead center of normal. It was not into the green. So I did start her on DHEA. And anecdotally, most of the professors give DHEA and pregnenolone orally. The medical literature says transdermal or oral. I did give her DHEA at 3.5 milligrams PO sustained release, and she takes that in the morning. With the progesterone, we always take that in the evening because as a pill, it can help with the insomnia. So in review of this case, we started her on a little bit of Biast as a cream. We started her on testosterone as a cream. I did not mix the two together initially because if you mix them together initially and you need to change one, the patient would have to throw it away. So if they've not been on those hormones before, I keep them separate. You can mix them in the same syringe or pump later on. I did back down on her progesterone. She was at 300. We went down to 130. I did go and start her on DHEA. And I gave her 3.5 milligrams SRQAM, all of this compounded. And then 4 cortisol stress reduction techniques, multivitamin, adaptogenic herbs, and calming herbs. So that's what we did for this patient. And she actually did quite well. Questions?
Hi, Dr. Smith. Yes, we do have a question. Why do cortisol levels take so long to normalize?
That's a great question. It really does take a long time for them to normalize. Part of that is because they really do interface with almost all the other hormones in the body. So the patient is stressed. It interfaces with insulin. It interfaces with thyroid, interfaces with all the sex hormones. So they all have to go back and normalize and sort of play in tune in the symphony. Also, when we give the other hormones, it resolves the issue. But a lot of times the patient really isn't willing to do what it takes to decrease stress. And they forget to take their adaptogenic herbs. They don't do stress reduction techniques. So it does take a little while for that to improve.
Great. I have another question. Other than the convenience, is there a difference between topical application of hormones and subcutaneous pellets?
Yes, there is a difference. When you put something on transdermally, then if you need to change the dosage, you can easily. Okay. If you have a pellet inserted and it's the wrong dose, then you'll have to take the pellet out. Sometimes you can't find them. When you put something on transdermally, it is very easy to do. When you do a pellet, it's more invasive. Also, unless you go to great expense, pellets are not 100% sterile. It's certainly not wrong to do pellet therapy, but it is something that is a little harder to personalize. Per Dr. Rebecca Glazier, who has the biggest sampling of pellet therapy in North America given to patients, Dr. Glazier, and again, this is not my area of expertise, this is per Dr. Glazier, suggests we don't do estrogen pellets. She believes that it's too hard to control bleeding if it becomes abnormal, etc. She still does do testosterone pellets, but per the expert in this area, I would not suggest estrogen pellets. Okay?
Great. What is the correlation of cortisol in blood and salivary?
Well, when we look at cortisol in the blood, the norms are really set there to do AM and PM, and they're standing and supine. Okay, so they have to be done right to begin with. If we're considering Addison's disease, then we do need to do an ACTH stimulation test. And by serum, we also need to measure ACTH and aldosterone. So they're really not designed to do the same things. The serum cortisol is more designed to look at Addison's or Cushing's as opposed to a salivary looking at hormonal balance. And there's actually 6 trials that are controlled trials to show that. And in Module 1, we give you a lot of references for everything so that you have references for all of this.
Great. We'll take one final question. Is cortisol retested in 90 days like other hormones?
Yes, it is, because we're looking at hormonal balance, even though we know many times it's not going to be normal, and it probably won't be in this patient, but we still measured anyway to see if we're getting improvement and to see what its balance is with the other hormones. So let's go on to case number 2. This is a 59-year-old male who presents for a follow-up visit. He feels much better since he started testosterone, but his wife has noticed that his breast tissue is slightly more pronounced. Past history is unremarkable. Family history, his father died of an acute MI at the age of 82. This patient is retired and he golfs every other day. He's on testosterone cream 5 milligrams and pregnenolone 30 milligrams POSR. Physical examination was non-contributory. So again, a 59-year-old male. He is already on hormones, but now he's getting increased breast tissue. So what do we want to do with him? Well, we did a salivary test on this patient, and we should measure estrone and estradiol both. In this particular case, the tube spilt onto the way to the lab, so we did not get estrone. We did get estrol, and it was indeed high. So we need to lower his estrogen. And what we did is, there's many ways to lower it. You can use Arimidex. You can look at giving zinc. You can look at grapeseed extract. My personal favorite is to give Chrysin, ChrYsin, as a cream. You can mix it right with testosterone in the same syringe, and it has no side effects and very effective to lower estrogen levels. So this person's on 5 milligrams of testosterone. His testosterone level's fine if you look at this lab. And so I gave him 2.5 milligrams of Chrysin in the same syringe with the same dose of testosterone. Progesterone is becoming more important for males, so we measured progesterone in this male and it was normal. Progesterone may help with prostate health, but it definitely helps with nerve endings and memory. He was not on DHEA, and again, we want the labs to be dead center of normal. Men need more DHEA than women. He was only at 5.4, so I gave him 10 milligrams of DHEA POSR. The gut does have to be healthy if we want to use sustained release. We talk about gut health in Module 3. And then you can see that his cortisol level is not entirely normal, particularly if you look at the graph at the bottom right hand as you face your computer. So we did a multivitamin, stress reduction techniques, and adaptogenic herbs. He was not particularly wired, so I didn't give him calming herbs. Questions?
Dr. Smith, so far we don't have any questions.
Males are a little bit easier by and large than females. So let's do another male and then we'll go back and do a couple of women. This is a 64-year-old male. The chief complaint that he falls asleep after dinner. Past history is unremarkable. He's an auto worker. He's on testosterone, DHEA, and pregnenolone. He has no other complaints. He's just tired after dinner. Physical examination non-contributory. When I first started doing this kind of medicine, I basically had an all-female practice. And over the years, it's evolved to now it's 42% males. Because if you fix him or fix her, you need to fix him. In this case, we need to fix his fatigue because she'd rather go out dancing. So here's his saliva test. His estradiol and estrone are normal. Progesterone is in lower limit of normal, but I opted not to replace that. But even though he was on testosterone, his testosterone was low. So one of two things is going on. Either he was not rubbing it in well, because they do need to rub it in for 2 minutes. The most common place that testosterone is applied for males in North America is the inner thigh, because men have less hair there. But as you know, testosterone can be applied in other locations. So I did take him from 17 to 25 milligrams of topical testosterone. He was on DHEA at 20 milligrams. He was not dead center, so I increased it to 30 milligrams. And I did compound it. He had been on over-the-counter. I compounded it with his pregnenolone. His pregnenolone level was 60, and that's a serum test, and that's fine. Pregnenolone by serum needs to be at least 50 to maintain memory. So again, I increased his DHEA to 30, and I compounded it in the same pill with his pregnenolone, keeping the dose at 50. His cortisol was abnormal. You can see on the graph at the bottom there. It was very, very high in the evenings, which is part of the reason why he was tired as well. So again, the same things, multivitamin, stress reduction techniques. I did have him take calming herbs 2 to 3 times a day and adaptogenic herbs. Questions?
Dr. Smith, how much rhodiola do you use?
Well, usually herbs are, they're hot and cold. So they're given in combination, usually. So it's rare I give them by themselves. Sometimes if I do give rhodiola, it's 200 milligrams. Or more commonly, I would give it with ashwagandha, ginseng, etc. Now, there are about 1 to 2% of people are very sensitive to ginseng. So if you start the patient on it and they call you back and they say, yeah, I have more energy, but now I'm anxious or I'm wired, then you may need to take them off ginseng. But that only happens in 1 to 2% of people. Other questions?
Yes. Is vitamin D part of your assessment since it is a pro-hormone?
It is, but not, I personally would not do it at this office visit. One of the things that's important to understand here is that you can't fix everything all at once. You get so excited about this kind of medicine, it really does reignite your love for medicine. It truly, truly does, because you can personalize everything for everybody by looking at their metabolism, at the science. But you can't fix everything at once because the body will get very confused and so will the patient. So would I do vitamin D? Yes, but I probably wouldn't do it at this office visit. I would do it at the next one when I repeated the hormones.
Okay. Why are they both on DHEA and pregnenolone? One the previous case, why not do weight loss and bring down the estrogen level?
You certainly could do weight loss and bring down the estrogen levels. But if you noticed, I said his physical examination on this case was non-contributory. So he actually was normal weight. So weight loss in this particular patient would not be helpful. But you're right. In a patient that's overweight, losing weight would lower his estrogen.
Okay. Could this male patient be experiencing negative feedback on his T production since his dose above the normal dose?
Its dose is really not above a normal dose because not all of it gets absorbed. So you can probably go up to 50 milligram cream without it going too high. So no, I don't think that would be an issue with this patient. Plus, he's already 64 years of age, so he's not going to be producing a lot of his own testosterone. So you can't really negatively affect the feedback mechanism.
Okay, great. I think that wraps up the questions for this case.
Okay, let's move on to a younger patient. This is a 20-year-old patient with the chief complaint that she does not cycle on a regular basis. It can be normal to have irregular cycles until the age of 18, but after that, the cycles should be regular. Past history is unremarkable. Family history unremarkable. She's a college student. She's not on any medicines. Review of systems was negative, and physical examination was entirely normal. And again, these are my patients. So what do we want to do with this 20-year-old female? Well, what I'd like to do in women that are 42 and younger is to do a 28-day saliva test. It's 11 days of specimens during that 28-day period of time. And this gives me a really good idea about what's going on. So on this 28-day test, there is melatonin. This is her melatonin. It was normal. On this graph, you see three things: estradiol, progesterone, and testosterone. On the upper graph is estradiol. The darker shade of the teal greenish area is where the patient should be, and the connected black squares are her specimens of estradiol. She's pretty normal until the last specimen, which is too high. So she's estrogen dominant. The middle graph is progesterone. Again, it should be the darker shaded area, so the dark blue, and it should go up with ovulation and progesterone should come down. In this case, the patient did not ovulate. The bottom graph is testosterone. Again, green's the average American, and the patient's high. So this is very representative of a patient with PCOS, polycystic ovarian syndrome. So what do we want to do? Number one, I'd like to detox her liver to get rid of some of that extra estrogen. So we can do a formal detox and help with phase 1, phase 2. Would I start her on some progesterone? I would. You can use transdermal or PO, and you would use it days 14 through 25 of her cycle. And you'll be able to tell when to give it by going back and sort of counting here on what you see happening. Her testosterone's too high. There's several ways you can lower testosterone. What I have to do with this patient was to give saw palmetto, 240 to 260 milligrams BID, and it very effectively lowered her testosterone. You do have to warn patients that they will become more fertile because when you give progesterone to this patient, it increases fertility. This next slide, at the bottom, you see her DHEA, which is entirely normal. The larger graph, again, is cortisol. She's normal in the morning and evening, but the mid-morning and mid-afternoon specimens are abnormal. So she's a college student, not unexpected. So actually, I just had her do stress reduction techniques and a multivitamin, and that was it. Questions?
So far, we do not have any questions on this case, Dr. Smith.
Okay. If you guys do come up with questions after the case is done, that's okay too, so no worries. Okay? Case number 5 is a 36-year-old patient with a chief complaint that she's been trying to get pregnant for 5 years with no luck. So someone has infertility if they've been trying for 1 year or more. Okay? Past histories are remarkable. Patient's on no medications. She's a physician. Father has a history of hypertension. Patient has a lot of stress in her job. She works over 100 hours a week. Of course, none of us fall in that category. Physical examination is unremarkable. So big problem here with infertility. So what I'm going to want to do, again, this is a younger female, so I want to do a 28-day saliva test. These are her results. This was melatonin. It's a little high in the morning. You can see on the first graph, which again is estradiol, she's very estrogen dominant. The second graph, progesterone, she did ovulate, but a little bit early and perhaps again later in the month. So could she achieve a pregnancy? Probably so, but she would have to have intercourse more frequently in order to achieve that pregnancy because she didn't ovulate at the usual time. Her testosterone was very normal, so she did not have PCOS. So from the perspective of this woman, is it possible for her to conceive and maintain a pregnancy? Probably so. Obviously, we still need to have the male checked. Do we want to do something with her estrogen dominance? Yes. And what I did is I put her on a 3-week detox program of her liver, and it brought down her estrogen very, very well. Her DHEA was high, so she was stressed. Her cortisol was low in the morning, high at 12 noon, and then normal the remainder of the day. So stress reduction techniques, multivitamin, and adaptogenic herbs. I did also give her calming herbs. I also advised her to try and not get pregnant for at least 1 year. A couple of reasons. First of all, she would probably miscarry because when people are very stressed, they either don't get pregnant or they miscarry. Men make less sperm and it's less motile. Also, we don't know what herbal therapies will do during pregnancy. They've not been studied in these particular kind of herbs. So that would be another reason for her not to try and get pregnant at this time. This patient did go on to achieve a pregnancy 2 years later. She did normalize, or closely normalize her cortisol, and actually her DHEA came down within 90 days. Questions?
Yes, Dr. Smith. Just referring back to the last case, I have a question about liver detox. Do you suggest liver detox to all your patients? What is your choice for that?
Well, I do suggest detox of the whole body, which there's 5 major organs of detoxification that you'll learn in the fellowship to all my patients. And sometimes I have to start with detox. I mean, if the patient comes in and they say that they're allergic to every class of antibiotics in the world, there really isn't any patient that is all of that. Okay? And so for that kind of patient, I actually start with detox. But you have to sit down and explain that to the patient as to really what you're doing. Okay. This 3-week detox I used on this particular patient was Ultra Clear Plus by Metagenics, but there's a lot of companies that make really good products. Again, this was Metagenics, Orthomolecular, Designs for Health, Thorne, Biotics, Douglas Labs, Numetica. I mean, there's millions of really good companies. And if you're asking what I used on this person, it happened to be Metagenics' Ultra Clear Plus.
Okay, which herbs or supplements you used for this patient to lower estrogen level?
Well, to lower the estrogen, again, I detoxed her liver with the Ultra Clear Plus. And if you're asking about the cortisol in this particular patient, I used Adrenovive, which is adaptogenic herbs by Orthomolecular, and I use Calmatrol, which is calming herbs by Orthomolecular. But again, a lot of companies make really great things. That just happened to be what I used for these particular patients.
Okay, and who offers the 28-day salivary testing?
This is a Genova test. And again, there's a lot of really good saliva testing companies. Okay.
And another question, would you check pregnenolone levels on this patient? What would be the ideal levels for a patient at this age?
The ideal lab levels are actually printed out on the blood work per age. So they vary slightly with different labs. So they're printed right on the test for you. Would I check pregnenolone? Probably not in someone this age group, unless I had another reason to that's not listed here.
Okay. And would you recommend oral versus IV detox?
Usually, I try and do things that are not as invasive if I can. We do IV therapies in our practice. One of my partners does our IV nutrients and chelation. But would I for this patient? Probably not. She's young. She's healthy. Her body will heal.
Okay, I think that wraps up the questions for that case.
Okay. Because our goal really here is to have hormonal balance and to help people achieve that. If they lose or gain 20 pounds, then you're going to need to go back and readjust their hormones. Because even though I'm talking about hormones right now, it's just as important, again, for the patient to eat right, to exercise, to be nutritionally sound, and to be hormonally sound. I just chose to talk about hormone dosing tonight because that's one of the hardest things that there is to do with hormones. And in module 1, we obviously teach this in Module 1, but we also have Ask the Professor Day for the modules twice a month, so that you can present your cases and we go over them with everybody in a webinar. And we also have webinars all the time like this on dosing and other things. So yes, you come to the module for 3 days or you take it 3 days online, but you have a big support system in the fellowship afterwards to help you, particularly with dosing. This is a 55-year-old female, the chief complaint of insomnia. She has a history of mitral valve prolapse. She's a school principal. She's on a sleeping agent. Review of systems is positive for anxiety, irritability, and mood swings, and she has fibroids. Okay? Fibroids are an estrogen-dominant state. Also, there's one study showing that fibroids are more common in women who eat a lot of red meat. So if she was eating red meat 7 days a week, then I would want to cut that down to 2 or 3 times a week. So here's her actual test. Her cortisol level is too low on all 4 specimens. She does have a fairly normal-looking DHEA. So this is someone who, when they're first stressed, cortisol elevates. When they've been stressed for a long time, it becomes too low. And so I did give her adaptogenic herbs. There are many other things you'll learn in Module 1 that we can do for low cortisol as well. And this is now called hypocortisolism or hypoadrenalism. It's not Cushing's. They do make some cortisol. And this is now actually a billable code. These are her results of this 55-year-old woman who is menopausal. She does have plenty of estrogen. So just because she's 55, if you didn't measure, you wouldn't know she has plenty of estrogen. So you would not want to give her estrogen. She doesn't have enough progesterone to balance that estrogen, so I would give her progesterone. And if you go back and look at her symptoms, anxiety, irritability, mood swings, and insomnia are low progesterone symptoms. So she's no longer cycling, so I would give her progesterone every day. And I gave her 100 milligrams POSR QHS. After about 6 months, as we normalize cortisol, then you want the patient to have a hormonal holiday. And one of the best ways for them to have a hormonal holiday when they're menopausal is to take the hormones Monday through Saturday and off on Sunday. There's other ways we'll teach you in Module 1 for the patient to take a hormonal holiday, but that's the easiest one. And her testosterone was fairly normal, as was melatonin. Okay, and she did very well with her progesterone and working with her abnormal cortisol. It did take this patient 2 years to resolve her cortisol, which is part of the reason that she had insomnia, not just low progesterone. With this patient, we did have to wean her off of the sleeping agent, and that did take about a year to do. Questions?
Dr. Smith, why not check thyroid in these patients?
I do check thyroid in all these. That's an excellent question. So all these patients also had thyroid done, and if it was abnormal, I would have mentioned it, but thank you for asking. They all had thyroid studies. And in Module 1, we discuss thyroid at length, and we look at optimal function of the thyroid and not just normal thyroid. And sometimes we even have to compound thyroid to get the right combination of T4 and T3.
What are the adaptogen herbs used and common herbs used?
Well, adaptogenic herbs, as I mentioned, some of them are like ashwagandha, ginseng, rhodiola would be the most common adaptogenic herbs.
How long do you do the hormone holiday? 1 month every 6 months?
No. Hormonal holiday, again, there's several ways of doing that, but the most common way is all the hormones Monday through Saturday and off on Sunday. So they will have 4 days to 5 days off every month. But if, a lot of women, another way of doing a hormonal holiday is all the hormones days 1 through 24 or 1 through 25, and then no hormones for 4 days. Some women get symptomatic when you don't give them hormones for 4 days. Their memory's not as sharp, etc. So you could do that. You could give the hormones days 1 through 25, then off for 4 to 5 days. That would be another method of doing that. They won't bleed because there's no abrupt withdrawal of progesterone.
How long do you continue supplement therapies after normalization of levels?
I'm not sure how to answer that one. I'm not sure which levels they're asking about.
Okay. Dr. Smith, what are some examples of stress reduction techniques?
Great question. Prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques, all of those. When I say exercise, I don't mean aggressive exercise. I mean an exercise that, is a moderate amount.
Did this patient have any thyroid problems, TPO
No,
plus?
no, she did not. Her thyroid was functioning perfectly.
What does the liver detox involve for bringing down estrogen levels?
Um, there's controlled trials with several different companies on actual different herbal therapies and nutrients that are put together to promote phase 1 and phase 2 detoxification of the liver, which is a whole hour seminar in itself we talk about in another module. But like the Ultra Clear Plus, it's a powdered drink with many nutrients and herbs in it that actually have controlled trials to show that it promotes phase 1 and phase 2 detoxification of the liver, so glucuronidation, acetylation, etc., are improved. And I love to use ones with actual controlled trials. That happens to be a 3-week detox. And there's a separate booklet that comes with it, and the patient follows the booklet so that they have a special eating program while they're detoxifying as well.
What testing for a 52-year-old female that has been bleeding for over a month since she is over optimal age for the 28-day saliva sampling?
Well, you can do a 28-day saliva test at any age. Okay. You could do a 6-day saliva test. And this patient, if she's bleeding that much, I would do a 28-day saliva test and see what's going on. So you can be any age to do that.
Okay, and last question. Did you check her vitamin D level?
Again, in these particular cases, I did not check it on the initial visit, no. Again, I'm not going to try and fix everything at one time. Could I have seen the patient and started with gut health instead? Yes. Could I have seen the patient and started with nutritional status like vitamin D first? Yes, absolutely. But again, you don't want to do it all at the same time.
Great. I think we're ready for case 7.
Okay, this is the last case this evening. 54-year-old female with anxiety, irritability, and mood swings. She's seen another healthcare provider for natural hormones. Physical examination unremarkable, social history. She works at a law firm as a law clerk, and she's on progesterone 150 milligrams PO and testosterone 4 milligrams PO. First of all, we don't use testosterone orally. Okay, so obviously this person that she saw in the past was not someone who was fellowship trained. These were her actual results. Her estradiol level was normal, but look at how high her progesterone was. The doctor that she saw in the past did not believe in testing. Her estriol and estrone were normal. Her testosterone was kind of normal. You could have given a little bit of testosterone. I opted not to. Her DHEA was low, and all of her cortisol was low. So what are you thinking? What you should be thinking is Addison's disease in this patient, because DHEA is low, all the cortisol is low, they're more than flatline. So you do need to send it to endocrinology for ACTH stimulation test. You do need to do an regular ACTH and aldosterone levels by serum, and that's actually the patient's diagnosis. Is the patient had Addison's disease. So don't forget regular medicine, because this patient could have died. Okay, the doctor she saw just gave her progesterone and thought that was just dandy and didn't do anything else. And that's what I just love about the fellowship, is that we love conventional medicine. We also have other things that we add to it that are based in science, and we look at the cause of the problem and not just treat the symptoms. And here we have a patient who literally could have passed away if she had not been treated appropriately. And that's our final case of the evening. Any final questions?
Yes. How do you prioritize which issue to address first in a complex patient with many complaints?
What a fabulous question. Great question. Actually, for all the years I've been practicing, what I usually do and I say to the patient is the following. What brings you in to see me today? Because if you don't address what brought the patient in, they're not going to stay your patient. So unless there's something that's life-threatening that they don't want to address, obviously you would have to address that first. But otherwise, start with where the patient wants to start. They want to start with weight loss, start with weight. There's many ways you can approach weight loss. So, start with where the patient wants to start. They're really not healthy until they're exercising properly, eating right, and their hormones and nutrients are balanced and appropriately given.
Great. Dr. Smith, I would like to thank you so much for participating in this webinar. I would like to thank all the listeners tonight. We do have a very special offer that I would love Dr. Smith to share with us.
Well, for any of you who will be attending Module 1, and obviously we'd love you all to be joining us for Module 1 in Hollywood, Florida. The hotel is beautiful. The property is fabulous. And I know you're going to be really, really thrilled with this module. We have world-class speakers teaching you, looking at hormonal therapy, looking at insulin resistance, looking further at the adrenals. We're going to discuss saliva testing and urine testing so that you want to be proficient in looking at both of those. We're going to look at bone loss. So really, there's a whole lot that we want to look at in this module. So we'd love to have you join us in Hollywood. So please call your A4M representative. If you sign up for this module before Friday, then you have a very special price of $2,000 for this module. So you absolutely want to do this. Please call your A4M rep. If you don't have a representative, you're not familiar with one, then Lindsay, can they call you?
Yes, absolutely. I was just going to give our phone number. The direct line will be 561-910-4960. You can also email me at Lindsay, Lindsay, at Tarsus, Tarsus, medicalgroup.com. That's Lindsay at tarsusmedicalgroup.com. MMI would like to thank everyone for their time, especially you, Dr. Smith. We hope that you had enjoyed the webinar. Please do connect with us to register for Module 1, which will be in Hollywood, Florida, May 7th through the 9th. And thank you, everyone, and have a fantastic evening.
Good night, everybody. Hope to see you in Hollywood. Bye-bye.